Congenital heart disease refers to structural abnormalities of the heart or great vessels that develop during intrauterine life. Intrauterine risk factors for congenital heart disease include maternal illness, such as diabetes mellitus and phenylketonuria, drug use including alcohol, lithium, thalidomide, phenytoin, and retinoic acid, and infections such as rubella. Congenital heart disease can also be associated with fetal genetic syndromes. Atrioventricular septal defect, ventricular septal defect, and atrial septal defect are associated with Down syndrome. Patent ductus arteriosus, pulmonary artery stenosis, and septal defects are associated with congenital rubella. Coarctation of the aorta and bicuspid aortic valve are associated with Turner syndrome. DeGeorge syndrome is associated with truncus arteriosus and tetralogy of Fallot. Supravalvular aortic stenosis is associated with Williams syndrome. Ebstein anomaly, which is apical displacement of the tricuspid valve leading to atrialization of the right ventricle, is associated with prenatal lithium exposure. Ventricular septal defect, patent ductus arteriosus, atrial septal defect, and tetralogy of Fallot are associated with prenatal alcohol exposure, while ventricular septal defect and transposition of the great arteries are associated with maternal diabetes during pregnancy. Congenital heart disease is classified by the presence or absence of cyanosis at birth or shortly after. Acyanotic congenital heart disease, also called pink babies, involves left-to-right shunts in which oxygenated blood is shunted back into the pulmonary circulation or may present with no shunt before congenital obstruction. Cyanotic congenital heart disease, also called blue babies, involves right-to-left shunts where deoxygenated blood is shunted into the systemic circulation. Cyanotic heart diseases are usually diagnosed prenatally or immediately after birth and typically require urgent surgical treatment and maintenance of a patent ductus arteriosus. Non-cyanotic heart shunts can be remembered with the mnemonic the 3DS, referring to ventricular septal defect, atrial septal defect, and patent ductus arteriosus. Cyanotic heart shunts can be remembered with the mnemonic the 5TS, which include truncus arteriosus, transposition, tricuspid atresia, tetralogy of Fallot, and total anomalous pulmonary venous return. Ventricular septal defect is the most common type of congenital heart disease, most often occurring in the membranous septum, in many cases resolve without intervention. Vactor LH association includes vertebral anomalies, anal atresia, cardiac anomalies such as atrial septal defect, ventricular septal defect, and patent ductus arteriosus, tracheoesophageal fistula, esophageal atresia, renal structural anomalies, limb anomalies particularly involving the radii and thumbs, and hydrocephalus. Acyanotic congenital heart left-to-right shunts may be asymptomatic at birth. The severity of clinical presentation varies with defect size. Each has a characteristic murmur. Ventricular septal defect is the most common. Patent ductus arteriosus is less common overall, but most common in prematurity. Uncorrected, clinically significant left-to-right shunts lead to increased pulmonary blood flow. Pathologic remodeling of vasculature, pulmonary arterial hypertension, and right ventricular hypertrophy, resulting in right-to-left shunt reversal known as Eisenmenger syndrome. A venous hum is a benign murmur that can be present in childhood. The murmur is a low-pitched, vibratory murmur that is heard near the clavicle throughout the cardiac cycle. Unlike the murmur of hypertrophic cardiomyopathy, a venous hum murmur is loudest when sitting and disappears with supine position or neck rotation. Septal defects are conditions in which a defective opening in the atrial or ventricular septum allows blood to flow between the atria or ventricles, leading to left-to-right shunting due to higher left-sided pressures. Ventricular septal defect is the most common type of congenital heart disease. Atrial septal defect is associated with Holt-Oram syndrome, fetal alcohol syndrome, trisomies 13, 18, and 21, and Turner syndrome. Ventricular septal defect is associated with Holt-Oram syndrome. Fetal alcohol syndrome, torch infections including toxoplasmosis, syphilis, varicella, Zika virus, rubella, cytomegalovirus, and herpes simplex, CRI-Duchat syndrome, trisomies 13, 18, and 21, and Turner syndrome. In both atrial and ventricular septal defects, small defects are asymptomatic, while large defects cause easy fatigability, failure to thrive, recurrent respiratory infections, and congestive heart failure. On auscultation, atrial septal defect presents with a wide and fixed split S2, a systolic ejection murmur at the upper left sternal border due to increased flow across the pulmonary valve, and a mid-diastolic rumble at the left sternal border due to increased flow across the tricuspid valve. Ventricular septal defect presents with a harsh holosystolic murmur at the lower left sternal border. Louder for small defects, a narrow S2 with a palpable thrill in large defects, and a mid-diastolic apical rumble due to increased flow across the mitral valve. Chest X-ray findings in both include cardiomegaly and increased pulmonary vascular markings. Echocardiography in atrial septal defect shows right ventricular hypertrophy, right atrial enlargement, and a defect with blood flow across the atrial septum. In ventricular septal defect, echocardiography shows left ventricular hypertrophy, right ventricular hypertrophy in large defects, and the defect with blood flow across the ventricular septum. The size of the ventricular septal defect is inversely proportional to the intensity of the murmur. The smaller the defect, the louder the murmur. Atrial septal defect has a fixed, widely split S2. Most small atrial and ventricular septal defects close spontaneously and do not require treatment. Follow-up echocardiography is scheduled based on the size of the defect and clinical findings. Antibiotic prophylaxis is generally not needed before procedures. If congestive heart failure develops, the best initial treatment is medical management using diuretics, followed by positive inotropes and angiotensin-converting enzyme inhibitors. Surgical correction is indicated in symptomatic patients who fail medical management, in those under 1 year of age with signs of pulmonary hypertension, or in older children with large defects that have not decreased in size over time. Early correction prevents complications such as arrhythmias, right ventricular dysfunction, and Eisenmenger syndrome. Patent ductus arteriosus is a failure of the ductus arteriosus to close completely postnatally, resulting in a left-to-right shunt from the aorta to the pulmonary artery. PDA is associated with prematurity and congenital rubella syndrome. Patients with large defects may present with failure to thrive, recurrent lower respiratory tract infections, and congestive heart failure. Examination reveals a continuous machinery murmur at the second left intercostal space at the sternal border, a loud S2, a wide pulse pressure, and bounding peripheral pulses. Uncorrected PDA can eventually result in cyanosis, with blue toes and normal fingers, through an Eisenmenger syndrome. The best initial diagnostic test is echocardiogram, which will demonstrate the defect. Large PDAs will show left atrial and left ventricular enlargement. Doppler color flow will demonstrate blood shunting from the aorta into the pulmonary artery. ECG may show left ventricular hypertrophy, and chest X-ray may reveal cardiomegaly with large PDAs. The best initial treatment is indomethacin, a nonsteroidal anti-inflammatory drug. Unless the PDA is needed for survival, such as in transposition of the great arteries, tetralogy of Fallot, or hypoplastic left heart, or if indomethacin is contraindicated, such as an intraventricular hemorrhage. If indomethacin fails, or if the infant is more than 2 weeks of age, surgical closure is typically required. The mnemonic "come in and close the door" reminds that indomethacin is given to close a PDA. Coarctation of the aorta and bicuspid aortic valve are associated with Turner syndrome. In infants presenting in shock within the first few weeks of life, consider sepsis, inborn errors of metabolism, ductal-dependent congenital heart disease, usually left-sided lesions, and congenital adrenal hyperplasia. Coarctation of the aorta is a narrowing near the insertion of the ductus arteriosus, called juxtaductal, just distal to the left subclavian artery, leading to increased flow proximal to and decreased flow distal to the coarctation. It is associated with Turner syndrome, bicuspid aortic valve found in more than 2/3 of cases, and intracranial aneurysms. It is more common among males. Complications include heart failure, aortic rupture, endocarditis, and cerebral hemorrhage due to Barry aneurysms. If not detected on newborn screening, coarctation may present in childhood with asymptomatic hypertension, particularly in the upper extremities. Classic physical examination findings include systolic hypertension in the upper extremities, low blood pressure, and weak or delayed pulses in the lower extremities, known as brachiofemoral delay. The difference in blood pressure between the left and right arms can indicate the point of coarctation. A systolic ejection or continuous murmur may be heard in the interscapular region. Lower extremity claudication, syncope, epistaxis, and headache may also be present. In infancy, critical coarctation requires a patent ductus arteriosus for survival. Such infants may present in the first few days of life with poor feeding, lethargy, tachypnea, and an eventual shock-like state when the PDA closes. During newborn screening for coarctation of the aorta, differential cyanosis may be seen with lower oxygen saturation in the lower extremities or postductal areas, compared with the right arm or preductal area. Clinical case. A 2-year-old boy is brought to the pediatrician because of shortness of breath and easy fatigability during play. Physical examination is notable for tachypnea and a harsh 2/6 holosystolic murmur over the lower left sternal border. Was the most likely cause of the boy's symptoms? This boy probably has a large, untreated VSD that is presenting with CHF. There is less turbulence across a large defect compared with a small one, leading to a lower grade murmur. The best initial diagnostic test is echocardiography with Doppler color flow. If presenting late in childhood or young adulthood untreated, chest X-ray will demonstrate cardiomegaly and pulmonary congestion in infants. And rib notching of the chest, due to enlarged intercostal arteries and the classic 3 sign created by aortic wall indentation with pre- and post-stenotic dilatation in older children and adults. In older children, compensatory left ventricular hypertrophy may be seen on ECG. The best initial treatment for severe coarctation in infancy is prostaglandin E1 to maintain ductus arteriosus patency prior to surgical repair. Surgical repair is performed in infants or toddlers, or balloon angioplasty in older children, with or without stent placement. Long-term monitoring is necessary for persistent hypertension, restenosis, aneurysm development, and aortic dissection. Cyanotic congenital heart right-to-left shunts are characterized by deoxygenated blood bypassing the lungs and entering the systemic circulation, leading to central cyanosis that typically presents soon after birth. The major cyanotic heart defects can be remembered by the mnemonic, the 5TS, which include truncus arteriosus, where one arterial vessel overrides the ventricles. Transposition of the great arteries, in which the 2 great arteries are switched. Tricuspid atresia, involving absence of the tricuspid valve, tetralogy of Fallot, which consists of 4 structural abnormalities, and total anomalous pulmonary venous return, described by 5 words. A key diagnostic fact is that cyanotic congenital heart disease does not respond to the 100% oxygen challenge test, as there is minimal effect on arterial oxygen tension, PaO2, whereas most pulmonary pathologies will show improvement with administration of 100% oxygen. Transposition of the great arteries is among the more common cyanotic congenital heart conditions in newborns. In this defect, the aorta arises from the right ventricle anterior, and the pulmonary trunk arises from the left ventricle posterior, resulting in separation of the pulmonary and systemic circulations. Life is incompatible unless a shunt is present to allow mixing of blood, such as a ventricular septal defect, VSD, patent ductus arteriosus, PDA, or patent foramen ovale. A PDA alone is usually not sufficient to allow adequate mixing of blood. Risk factors include mothers with pre-existing diabetes and rarely DeGeorge syndrome. Transposition of the great arteries typically presents within the first few hours after birth and is not affected by exertion or supplemental oxygen use. Reverse differential cyanosis, in which higher postductal saturations than preductal saturations are seen, may occur if left ventricular outflow tract obstruction, such as coarctation or aortic stenosis, is also present. Physical examination reveals tachypnea, progressive hypoxemia, and extreme cyanosis. The patient may have congestive heart failure, a single loud S2, and a systolic murmur if coexisting with VSD. The best initial test is echocardiography, which shows abnormal formation of the great arteries. Classic chest X-ray may show a heart with an egg on a string appearance. The best initial treatment is intravenous prostaglandin E1, PGE1, to maintain or open the PDA. To allow some time for growth for a more successful surgical outcome, a balloon atrial septostomy is performed to create a shunt that is not reliant on the PDA and prostaglandin infusion. The most definitive treatment is surgical correction with an arterial switch operation. Tetralogy of phallic consists of right ventricular outflow tract, RVOT, obstruction, overriding aorta, right ventricular hypertrophy, RVH, and ventricular septal defect, VSD. It is among the more common cyanotic congenital heart diseases in children. Early cyanosis results from right-left shunting across the VSD due to high right-sided pressures from RVOT obstruction. As right-sided pressures decrease in the weeks after birth, the shunt direction reverses and cyanosis resolves. If the degree of pulmonary stenosis is severe, the right-sided pressures may remain high and cyanosis may persist. Risk factors include trisomy 21 and DeGeorge syndrome. The mnemonic ck2 represents DeGeorge syndrome features. Cardiac abnormalities such as TOF or VSD, abnormal facies, thymic aplasia, cleft palate, hypocalcemia secondary to hypoparathyroidism, and 22q11 deletion. TOF presents in infancy or early childhood with dyspnea and fatigability. Cyanosis is frequently absent at birth, but develops over the first 2 years of life. The degree of cyanosis often reflects the extent of RVOT obstruction. Infants are often asymptomatic until 4 to 6 months of age, when congestive heart failure may develop and manifest as diaphoresis with feeding or tachypnea. Children often squat for relief during hypoxemic episodes called TET spells, which increase systemic vascular resistance, thus increasing blood flow to the pulmonary vasculature and improving oxygenation. Hypoxemia may lead to failure to thrive and developmental delays. Physical examination may reveal a systolic ejection murmur at the left upper sternal border due to pulmonic stenosis and a harsh holosystolic murmur at the left lower sternal border due to VSD. Both transposition of the great arteries and tetralogy of Fallot are initially treated with prostaglandin E1, but are definitively treated with surgical correction. The best initial diagnostic tests are echocardiography and catheterization. Chest X-ray shows a boot-shaped heart with decreased pulmonary vascular markings, while an isolated VSD without RVOD may show increased pulmonary vascular markings. ECG shows right axis deviation and RVH. The best initial treatment, if there is severe RVOT obstruction or atresia, is emergent administration of prostaglandin E1 to keep the PDA open, in conjunction with surgical consultation. Treatment of cyanotic TET spells includes supplemental oxygen and placing the patient in a knee-chest position. If further treatment is needed, intravenous fluids, opioid analgesia, beta blockers, or alpha agonists can be considered depending on the context. Temporary palliation can be achieved through creation of an artificial shunt, such as a balloon atrial septotomy, before beginning multi-step surgical management, with a modified Blalock-Thomas-Taussig shunt often being the first step.